This is case number 1 from the OPD Red Flag Files. She was at home, making dinner, maybe, watching TV, breathing. Then suddenly she couldn't. Her chest tightened, her heart raced. She tried to stand, but her legs gave way. 6 hours earlier, she was in an OPD. A doctor told her she was fine. Now she is on the floor. Her family is calling for an ambulance. Her lips are turning blue. Pulmonary embolism, a blood clot in her lungs. She survives, barely. 3 months later, her family files a complaint, not out of anger, out of confusion. How did this happen? They sit with a lawyer. The lawyer pulls out the OPD notes. He reads aloud. Vitals normal, chest clear, patient reassured. Then he asks one question. Did the doctor check her oxygen after she walked? The family looks at each other. They do not know what that means, but the lawyer does, and so does the medical council. That question changes everything. This is Dr. Ravi Chani. I analyze cases where things went wrong, so we can learn what to do differently. This is case number 1 from the OPD Red Flag Files. Now, let me take you back to that morning. A 28-year-old woman walks into an OPD. She is short of breath, not severe, just a tightness in her chest when she walks. The doctor checks her vitals, oxygen saturation, SpO2, 98%, heart rate, 82, blood pressure, normal, chest auscultation, clear, no wheeze, no crackles, no rub. The doctor reassures her. Probably anxiety, he says. Maybe deconditioning. Go home, rest, you will feel better. She walks out. 6 hours later, she collapses. Pulmonary embolism, a blood clot in the lungs. Now, here is a statistic that stops me every time. A 2019 meta-analysis in JAMA Network Open looked at over 2,800 patients with confirmed pulmonary embolism. So, let us start with the obvious question. How can someone have a life-threatening condition and still show normal vitals? The answer lies in something called compensatory reserve. Young, healthy bodies are incredibly good at compensating. They work harder behind the scenes to keep the numbers normal. But here is the catch. A 2018 review in critical care clinics described this as the illusion of stability. Normal vitals do not reflect normal reserve. They reflect the body's temporary ability to compensate. That is not stability. That is borrowed time. So, what did the doctor miss? He mistook temporary compensation for genuine safety. He looked at the numbers and stopped thinking. That is called anchoring bias. You anchor to normal vitals and ignore the possibility of serious illness. So then, the next question becomes, if resting vitals are normal, what should we be looking at instead? Exertional desaturation, a drop of 3 to 5% when the patient walks. So, here is where guidelines become your shield. The 2020 European Society of Cardiology Guidelines on Pulmonary Embolism explicitly state, assess exertional oxygen saturation in patients with suspected PE, but normal resting vitals. That is not a suggestion, that is the standard of care. So when the lawyer asked, did the doctor check her oxygen after she walked? He was not being clever. He was reading the guideline. Which leads to an uncomfortable question. When was the last time you checked oxygen saturation before and after a patient walked? Let me walk you through 4 conditions that hide behind normal vitals. Each has a guideline. Each has a reason why it gets missed. 1. Pulmonary embolism. The 2020 ESC guidelines state that up to 30% of stable PE patients have normal oxygen saturation, normal heart rate, clear lung fields. So what is the clue? Did the patient walk to your clinic? How did they feel after? Why do doctors miss this? They assume if oxygen is normal at rest, the lungs are fine, but the clot does not affect oxygenation until the patient exerts themselves. The doctor in this case did not ask the patient to walk. He anchored to the normal numbers and stopped. Here is the guideline. The 2022 CHEST guidelines validated the PERC rule, pulmonary embolism rule out criteria, in over 8,000 patients. PERC negative patients have a less than 2% risk of PE. That is 0 out of 8 criteria. No testing needed. But here is the trivia that matters. One positive criterion: age over 50, heart rate over 100, oxygen under 95, prior DVT or PE, recent surgery, hemoptysis, unilateral leg swelling, estrogen use. Any one of those means you need a D-dimer blood test. And if the D-dimer is positive, you need imaging. 2. Myocarditis. A 2021 study in Circulation found that over 40% of patients with confirmed myocarditis had normal initial troponin levels. The enzyme rises late, sometimes 12 to 24 hours after symptom onset. Why do doctors miss this? Here is the guideline. The 2021 ESC position paper on myocarditis says this: recent viral illness is the most consistent red flag. Upper respiratory symptoms in the preceding 1 to 3 weeks. Do not wait. Arrange cardiology. Get an echocardiogram. 3. Early pneumothorax. A 2020 systematic review in the American Journal of Emergency Medicine analyzed 1,200 cases. Nearly 15% had normal inspiratory chest x-rays. Why do doctors miss this? Pneumothorax. But a small pneumothorax is often invisible on inspiratory films. The doctor in this case would have seen a normal chest x-ray and stopped. He did not know that a small pneumothorax hides in inspiration. Here is the guideline. The British Thoracic Society guidelines say this: if clinical suspicion is high, sudden onset, tall thin habitus, pleuritic pain, obtain expiratory chest x-ray or CT. Expiratory views make the visceral pleural line visible. Inspiration hides it. Expiration reveals it. 4. Early sepsis or diabetic ketoacidosis, DKA. The patient is breathing fast, really fast, but blood pressure is normal. Heart rate is normal. Why do doctors miss this? They see normal vitals and think the patient is stable, but the patient is breathing fast because the body is compensating for metabolic acidosis. The doctor in this case would have seen normal BP and normal heart rate and felt reassured. He did not check a venous blood gas. He missed the acidosis because he trusted the vitals. Here are the guidelines. The Surviving Sepsis Campaign guidelines state that compensated metabolic acidosis can present with tachypnea and normal vitals for hours. What reveals it? A venous blood gas, low bicarbonate, below 22, or high lactate, above 2. That tells you what vitals cannot. For DKA, the American Diabetes Association guidelines state that normotensive, well-hydrated patients can have normal vitals despite ketosis. So here is the pattern. Resting vitals give false reassurance. Guidelines exist precisely to prevent this. Are you using them? Now let us switch sides. What does this look like from the patient's perspective? She trusted her doctor. She was told her vitals are normal. She was told it is probably anxiety. She was reassured, so she goes home. When it gets worse, what does she ask herself? Am I overreacting? The doctor said I am fine, so she delays. She waits. By the time she cannot breathe, she is on the floor. Her family is calling an ambulance. Why does this happen? This is the reassurance trap. The doctor's reassurance becomes a barrier to care. The patient stops trusting her own body. She delays seeking help because she was told she was fine. Here is the statistic. A 2019 study in Diagnoses analyzed 1,000 diagnostic error cases from the CRICO database. Over 40% of diagnostic errors in outpatient settings involve patients whose symptoms were dismissed as benign or anxiety-related, only to be diagnosed with a serious condition within 7 days. So here is a hard question for doctors. When you reassure a patient, are you also giving them a safety net, clear instructions on when to return, or are you just moving to the next patient? Now, let us look at the legal lens. Remember the lawyer's question? Did the doctor check her oxygen after she walked? That question is now at the center of the case. The attorney does not need to prove malice, just that the doctor failed to follow the standard of care. Here is how the argument is built. The patient presented with shortness of breath. Cardinal symptom, demands investigation. The doctor performed only resting vitals, did not assess what happened on exertion, did not document functional capacity. The doctor anchored to normal numbers, dismissed the symptom without a clear list of possible diagnoses. The doctor gave no safety netting instructions, no guidance on when to return or go to the emergency department. The patient deteriorated, harm that could have been prevented. In legal terms, this is negligent omission, failing to do what a reasonable doctor would have done. Why is this case indefensible? Because the doctor did not perform the basic steps any reasonable doctor would have done. He did not assess exertional status. He did not document his reasoning. He did not safety net. The court does not care that the vitals were normal. They care that the doctor did not do his job. The question that matters: does the court care that the vitals were normal? No. They ask, did you perform an adequate assessment? Did you document your reasoning? Did you safety net? In my review of cases, the presence or absence of a single sentence often determines the outcome. Patient desaturated on ambulation. So let us end with the most important question. What can doctors do to protect their patients and themselves? 3 things, and they all come from the guidelines. 1. Stop anchoring to resting vitals. Ask yourself, am I mistaking temporary stability for safety? 2. Perform exertional assessment. The ESC guidelines say it. The chest guidelines say it. Ask the patient to walk. Check oxygen before and after. Document the result. That transforms a subjective complaint into an objective finding. 3. Document your reasoning, not just patient reassured. Write your differential. Write your plan. Write that you safety netted. Here is the kind of documentation that holds up. Patient reports shortness of breath on minimal exertion, unable to walk 1 flight of stairs without stopping. Vitals normal at rest. Exertional assessment. Oxygen saturation dropped from 98% to 93% on walking, per ESC guidelines for suspected PE. PRC rule positive. Heart rate over 100 on exertion, prior OCPUs. Possible diagnoses include pulmonary embolism, myocarditis, and early pneumothorax. Wells score 4.5. D-dimer blood test ordered. Safety netting provided. Patient instructed to go to emergency department immediately if symptoms worsen. Here is the kind of documentation that holds up. That paragraph does 3 things. It shows you followed the guidelines. It demonstrates your clinical reasoning. It creates a legal record that protects you. One final thought. She walked into that OPD breathing. She walked out thinking she was fine. 6 hours later, she was on the floor. Her family at the hospital. A lawyer reading the notes. The guidelines exist. The evidence exists. The tools exist. The only question is, do we use them? This is case number 1 from the OPD Red Flag Files. I will be back with another case, another red flag, another lesson. Now I want to hear from you. Have you ever had a patient with normal vitals who later deteriorated? Drop it in the comments if you are watching on YouTube, or send me a message if you are listening to the podcast. If this was useful, follow RedFlagMD wherever you are. I will see you in the next one. Take care.